over at GW, where he's the Chief Quality and Population Health Officer and currently serving as interim chair of medicine. His background includes medical education at Hopkins, and he's been here in the DC area now, Bill, what, for about a decade now?
Yep, that's right.
He's been at GW, where he's a nationally prominent health services researcher and a clinical cardiologist with an interest in prevention. And it was about a month ago, I noticed this paper that came out in Circ Quality and Outcomes, and it's entitled Strategies to Reduce Low-Value Cardiovascular Care, a scientific statement from the American Heart Association. And it's about getting return on investment for our healthcare dollar and preserving those critical dollars we need to take care of cardiovascular and other health problems by saving dollars where it doesn't really provide return on the healthcare investment. So, and I really like this paper quite a bit. And I saw that Bill was the vice chair of the scientific statement. And I thought, perfect opportunity to have Bill, as a local expert to speak to us and to bring this important topic to us today. So, Bill, thank you so much for accepting our invitation and your bringing your time and your expertise to us today.
Well, thank you so much, Alan. It was really so kind of you to reach out, and I'm really honored to be able to give this grand rounds for neighbors here in DC. And saying hopefully at some point soon we will be able to meet up in person. We here at GW are also still doing medicine grand rounds virtually, but continuing to look at where things are going and look forward to in person. But I'm really glad to join you all. So thanks so much for having me. So I'm going to start, as Alan mentioned, this is the talk today is around strategies to reduce low value cardiovascular care. And just to start with my disclosures, I have no commercial entities, but I do lead population health here at GW for our faculty practice. I'm a member of the Medicare Evidence Development and Coverage Advisory Committee, and then for the American College of Cardiology on the Population Health Management Task Force. And where this all got started was a couple of years ago. I had the privilege of serving as the chair of the American Heart Association's Quality of Care and Outcomes Research Council. And as part of that, we developed scientific statements. And a wonderful colleague, Dr. Vinay Kinney, approached me about developing a scientific statement, and we'll talk about that in a moment. And so we got together and developed this scientific statement through the AHA, and then it was published just in the last month. But I want to start with a case, and this is a patient that I saw recently, the Cyclist. So a 60-year-old man with coronary artery disease, status post non-STEMI with PCI in 2016. Feels well, he's doing great. Bikes 20, 25 miles without symptoms, on rosuvastatin 40 milligrams daily. His exam's unremarkable, LDL is 56. And the question he asked me is, should I get a coronary calcium CT scan? And he says that the reason is he wants to know, how's his coronary disease doing? Is it progressing? Is it not? And so, for him, doing a coronary calcium CT scan would be really not add a lot or really anything in terms of his management. He's already on a high intensity statin and his LDL is well controlled. He's on the other secondary prevention medical regimen. And we know that he has atherosclerotic cardiovascular disease because he had an MI. So this really wouldn't add value for him, even though it is something he's read about and is interested in getting. And so we're going to talk a little bit more about where these sort of tests fit in as what would be considered low value care. And so it was kind of cases like that led Vinay and myself and our colleagues, who you can see here, to work on the scientific statement. That'll be the basis for today's talk. So, we've seen data like this for many years, and this is some data from a couple of years ago out of the Kaiser Family Foundation. But when we look at the United States in green, compared to peer nations around the world, we come in last in terms of healthcare quality and access, basically our outcomes, our healthcare performance. And I think we've seen this in various forms. But where we excel, or if you can call it that, is in terms of spending, where compared to the average across those comparable countries, we're about double. So we spend a lot of money on healthcare, and we don't necessarily get the outcomes that other countries get, despite spending that. So really kind of a lousy deal in terms of spending a lot and not getting the outcomes that we deserve for our healthcare. And when we look at this, there was a nice study a couple of years ago which looked at waste in healthcare across the US and divided it into a variety of different categories. And this is in US dollars in the billions. And what you can see is that one of the big categories is overtreatment or low value care. That, on the upper end is as much as $1 trillion a year. So really pretty substantial. And one of the points of this scientific statement that we'll get into are some of the ways that we can reduce that low value care, always with keeping at the center of our attention the patient, and making sure that we're doing the right thing clinically for our patients. So this brings us to the concept of value. And this was sort of initially really championed by someone named Michael Porter. And this concept of value being the health outcomes that we get, and at what cost. And I think, and as we all do in the medical field, that outcomes come first. So first and foremost, we need to make sure that we're doing the right thing medically and in terms of the health of our patients. But I do think we do have an obligation as physicians to consider the cost. Because if we are not good stewards of the healthcare dollars that society puts towards healthcare, then those are funds that don't go to other societal priorities, like education or the environment or national security or cutting taxes, whatever your priorities might be anywhere on the political spectrum. It's obviously, we want to be good stewards of those dollars. But we do have to first and foremost focus on making sure that we're getting good health outcomes for our patients. So stemming from that, what's the definition of low value care? So healthcare services that really provide no net benefit from a cost benefit perspective. And we'll dive into this a little bit further. And thinking about this, when you weigh the benefits and then the potential harms, and the benefits, obviously, if we do a test or a treatment, if we diagnose or treat the condition, perhaps with a test we exclude a condition and that directs us to an alternate diagnosis. And sometimes the benefit is in providing reassurance to patients. On the harm side, though, that we need to weigh that against are complications and side effects, false positives, and we'll get into some more of the details on that, as well as incidental findings. And both those false positive incidental findings can also have implications in terms of anxiety or stress that it causes for patients, as well as cost and inconvenience, which is a factor, particularly as you see diagnostic testing cascades from incidental findings or from low value testing in general. So one of the things that we did in the scientific statement was we put this in a framework. And so first focusing on those outcomes and looking at established parameters like absolute risk reduction, patient-reported outcomes, with both which you want to be high, and then a number needed to treat, which you would want to be low. And then we cross that with the cost, which could be money, it could be other resources, but it also could be that physical toll, like side effects, or the emotional toll, the anxiety from, say, incidental findings that aren't of much clinical significance. And then we can categorize these from the highest value down to the lowest value, with obviously a greater focus on higher value being where you have greater outcome. But obviously there are a lot of complex reasons for why there is low value care. A big driver is misaligned financial incentives in our fee-for-service system. Defensive medical practice related to malpractice concerns is certainly a factor. Deference to patient requests for testing and treatment, like the example I gave at the beginning, where we talked about the patient who was asking about a coronary calcium score, something he had read about. We have non-evidence-based clinical heuristics. Heuristics are kind of shortcuts that we all take in our clinical decision-making, which may have been passed down to us over time, but may not actually be based on evidence. And then, of course, there are clinical practice cultures that can encourage excessive care. And certainly, this has been demonstrated by the work of the group at Dartmouth for many years now around wide variations around the country in terms of utilization of different healthcare practices that often don't connect to any difference in health outcomes. So one of the programs that has really been focusing on low value care and helping to, provide some guidance for providers around this is the ABIM Foundation's Choosing Wisely program, which really looks to professional societies. So for example, in cardiovascular care, the American College of Cardiology, in having physicians in those particular fields help to define what they see as low value care within their field. So this is driven by the physicians themselves in their particular areas. And it's not just in cardiology, but it's in a whole range of fields. And you can go on the Choosing Wisely website and see their lists that are there, and as well as their methodology and how they go about this. And it's really about, as they say here, promoting that conversation between patients and their clinicians. So this isn't this isn't carved in stone, a hard and fast rule, but this is a way to provide some basis for that conversation. And here are some examples that we pulled out in the cardiovascular space, and I won't read through all of these, but something that is high value would be stress testing in an asymptomatic patient who's at intermediate risk for coronary artery disease. Exactly where something like stress testing can be very beneficial. If someone is high risk, and symptomatic, then they should go forward to catheterization. If they're low risk, then and asymptomatic, then you don't need any additional testing. But routine annual stress testing after coronary revascularization is something that would be lower value care. And then you can see also the example of coronary calcium scoring and intermediate risk for ASCVD when you're trying to make a decision about statin use. And as compared to coronary calcium scanning in patients who have known coronary vascular disease, where it's not really going to change your management at all. So with that sort of basis and talking about low value cardiovascular care, the rest of the talk I'm going to cover three main areas. We'll talk about the scope and impact of low value cardiovascular care, interventions to equitably improve, and then a framework that we developed around reducing low value care. So first, let's talk about the scope and impact. So getting back to that value equation that we talked about initially, where we look at the health outcomes over the cost. With that basis, it's really important to think about how this is all measured. And so some of those key parameters are, what's the outcome and over what time horizon? And that's important because if you're thinking about outcomes over 20 or 30 years, it's different than outcomes maybe within an individual hospitalization. And then it's important to think about this from the perspective, from whose perspective? The patient, the clinician, the health system, the payer, or from society as a whole. So for example, if you look at a particular health outcome, from a clinician's perspective, it may be that a surgery was a success if there were no complications. From a patient's perspective, it may be their pain management, may be the key health outcome that they're concerned about. And similarly, from cost, it depends on what perspective you're looking at it from. So there could be a test that may be low value, but from a patient, they have no out-of-pocket costs. So the cost to them, other than their time and having to go through the test, is really zero. But from a payer or society perspective, there is a cost there. So we tried in this to look at it across these different perspectives as much as possible. And the sources of data are also important, and they all have kind of their strengths and their weaknesses. So there's administrative data, sort of claims data. There's electronic data coming out of the electronic health records, which, as we all know, is only as good as what data is put in. There are manual chart abstractions, but of course that's time intensive, and there has to be inter-rater reliability with that as well. And then there's been a lot of work in recent years, and particularly in the cardiovascular space, around patient-reported outcomes. So looking at quality of life scores for things like heart failure and angina. And then, looking at what are those metrics that we're looking at for both the outcome and for cost. And metrics, as we talked about, could be mortality and morbidity, could be lab values, patient-reported outcomes, or it could be things like absenteeism. So how often does someone have to miss work because of some condition or because associated with some test or treatment. And then obviously with measurement is also the strength of the evidence with the outcome. So when we look at a test or treatment, how well do we know, how strong was that study? Was it a large randomized controlled trial, well done? Or was it a observational study, which would perhaps provide us with weaker evidence? And then when we look at the cost, we look at metrics, obviously financial metrics, but also things like disability for a patient, inconvenience. And often the way that this is looked at is using cost effectiveness ratios, which can vary. Although, at least in the US, often it's seen that $100,000 to $150,000 per quality adjusted life year is generally considered to be something that is cost effective. But that's a decision that we make sort of as a society in terms of what we consider to be cost effective and that sort of dividing line between low value and high value. So one way that this is all put together are through what are called appropriate use criteria. And the American College of Cardiology has a task force that works on this, and they've been doing this for many years. But with the most recent update to their methodology in 2018, they talk about an appropriate diagnostic or therapeutic procedure is one in which the expected clinical benefit exceeds the risk of the procedure by a sufficiently wide margin, such that the procedure is generally considered acceptable or reasonable care. And so, this is helpful, and the ACC puts out, all kinds of appropriate use criteria in different categories, whereby you can look at a particular test or procedure and see its level of appropriateness. And so when we look at sort of the prevalence and look at something like, non-invasive testing, this was a study from several years ago and looked at progression over time for transthoracic echocardiogram, transesophageal, stress echocardiogram, CT angiogram, and SPECT nuclear imaging. And what you can see is that there were some improvements for TTE, for CT angio, and for SPECT. For TTE, TEE, and CTA, but not for stress echo and SPECT over time, although not, substantial improvements. And you can see that, for areas like stress echocardiogram and CT angiogram, the appropriateness of the testing still remained pretty low back as of at least 2015. When you look at something like a non-acute PCI, there we've seen some more improvements. And as you follow this over time from 2009 to 2014, you can see that the appropriateness went up from about 30% to over 50%, with those categorized as uncertain or inappropriate decreasing over time. But still obviously room to go if we were to look at overall appropriateness at just over one out of every two non-acute PCIs being appropriate nationwide. And this applies to some of the newer technology. I'm sure you all are seeing this as well in terms of patient wearables. Those are tests. Those are tests that we should look at through the same rubric around low or high value care. Certainly their patient spends money to get these devices, but then there's downstream effects from this testing. And around 50 million Americans now are using heart rate or physical activity monitors. And so this is one getting a ECG, a single lead ECG tracing from a particular app. And so this was an interesting study which looked at this. And when you look at the app algorithm by itself, only about 2/3 of those tracings were interpretable by the app itself. When a physician reviewed those, they became more interpretable. Those that were interpreted were relatively reliable with a 93% sensitivity and 84% specificity compared to a 12-lead ECG. But it does raise that question of, what are the downstream effects, whether it's, calls or messages to the primary care provider or the cardiologist, or potential downstream testing associated with potentially uninterpretable testing off of the algorithm. So the other piece that we see here, and I think we've all experienced this, is sort of cascade of testing that happens from incidental findings. And so here was a study from a couple of years ago surveying primary care providers and asked them about whether they have either events or health outcomes that stem from incidental findings related to testing. And as you can see, when you look at sort of at least several times per year, the rates are quite high, generally, the 60 to 80% range for things like, new testing. But even when you look at ED visits, hospitalizations, it's around 50%, and as well as patient harm associated with it. And clinically important intervenable outcomes. And interestingly, that the numbers are relatively high, even when you look at monthly or at least weekly. And, drilling into this a little bit further in terms of other studies which have looked at the consequences of incidental findings. Here's for cardiac CT, and this isn't saying specifically whether that cardiac CT was low value or high value, but just when you look at the incidental findings, you can see that non-cardiac incidental findings, many of them were of without significant or indeterminate findings, but that there were patients who had those indeterminate significant findings. Some of them eventually led to, a death, one from cancer, but you can see that there's a cost associated with all of this downstream testing. And then it's important to look at other effects of testing. So when we're talking about, imaging testing like CT scans and sort of follow-up testing that may need to be done for incidental findings, it's also worth considering. And so, when you look at sort of healthcare workers, the threshold below which healthcare workers should be at is 100 millisieverts in 5 years, so about 20 millisieverts a year. And so you look at this large population of patients in this study that was looking at the amount of radiation dose annually. You can see that there is a significant number, about 1 in 5, who are getting radiation doses between 3 and 20 millisieverts. And we know that medical radiation years down the road can lead to both solid and hematologic cancer. So, something that, it should factor into our decision making and factor into that determination of whether something that may otherwise be a low value test is really worth doing. And when we look at the cost, when we look at low value cardiovascular services, the cost estimates, there's a wide range because, as we've talked about earlier, the data is not always great in terms of how we determine this. But as you can see that the annual cost estimates can be for things like low value stress testing or PCI for stable coronary disease, upwards of over $2 billion. Something like preoperative non-invasive stress testing, somewhere in the $100 to $200 million category. And then even something like preoperative ECGs, which often are not necessary depending upon the procedure, an estimate of around $35 million. And so when you look at this further, it's not just, testing like CT scans or stress tests or procedures like PCI, but it also can be in areas like medication use. And so the next two slides are going to look at a study looking at brand name drug usage when there is a bioequivalent generic medication. And what you can see, this was comparing a Medicare population to a population at the VA. And what you can see is that there was significantly more brand name drug use in Medicare than in the VA. And when you look at the cost, if you look at the far right here, the total column, the actual spending for Medicare Part D was about $1.4 billion more than the VA in that year. So, that's a low value treatment when you look at it in terms of there being a bioequivalent medication, but spending additional money on brand name medications. So, and then, what's sort of the patient-centered costs of all of this? And so when we look at this, there's a lot that patients think about as well. I'm really nervous that I have to get this additional test, time I need to get back to work, I worry about the risks. And then those patient costs, we're certainly seeing an increase across the country in what are called high deductible health plans, which is where patients pay a substantial amount of money out of pocket before their insurance kicks in to start covering some of those costs. So a lot of this additional testing may fall directly into that patient having to pay out of pocket. So next I'm going to talk about some interventions to equitably improve or low value cardiovascular care. And so, can this be done? Well, some estimates, and this was from that earlier JAMA study that I showed you, which looked at the costs of healthcare waste in this country. And the one that on the overtreatment and low value care, their estimate based on the data is that probably about $13 to $29 billion across the US overall could be saved with interventions to reduce low value care or overtreatment. So we looked at interventions in sort of two categories. So patient and clinician level interventions, as well as payer and policy level interventions. So let me start with the patient and clinician level interventions. So it's really in sort of five categories: patient education and shared decision-making, clinician education, and I link to that clinical audit and feedback, clinical decision support, and then behavioral science approaches, otherwise called nudges. Two of these I'm not going to go into much detail. It turns out that most of the literature on patient education, as well as on shared decision making and on clinical decision support, hasn't been overwhelmingly instructive in terms of reducing low value care. It hasn't really been proven to be the case. That doesn't mean that it's not beneficial. Some of these are difficult studies to do. It's just there's not a strong evidentiary base behind those. But a couple of the others I will talk about here. So when you look at clinician education, and this study actually includes audit feedback. This was a single center study which looked at an intervention within cardiology on educating on appropriate use criteria for ordering transthoracic echocardiograms. And so in the intervention group, they got education and then they got audit and feedback. So their echocardiograms were reviewed for appropriateness, and then that feedback was given to the cardiologist. The other group was education alone. And so what you can see is that that you saw an overall decrease in the intervention group of rarely appropriate TTEs. But you can see that also in the control group, there was potentially a decrease. It was not statistically significant, partially from that educational intervention, and then it was a single center study. So I'm sure they were, there's a certain culture to practice patterns. And so there may be some secular effects in terms of improving the appropriateness of the echoes that are ordered. So, there's some evidence to support these approaches. For nudges, there's a great book, if any of you have read it, called Nudge, which talks about sort of behavioral economic approaches. So how can we structure the menu of options such that we choose things that, that we as society, or in this case, what we decide is more appropriate low value care, how can we move towards that? And so here's an interesting nudge, which is that in a particular health system, this was at University of Pennsylvania, they implemented in November of 2014, where they put in a generic medication default order set. And I think, we have this, and a lot of places now have this, where the default is going to generic medications rather than brand. And what you can see is that across a wide range of medications, that the percentage of generic prescriptions went up pretty dramatically over that time, and really just a 2-month time period, and then continued that way for the 6 months that was studied thereafter. So those were some of the patient and clinician level interventions. Now I'm going to talk for a couple minutes around payer and policy level interventions. And so this is in 7 categories. So healthcare payer and system structure, national coverage determinations, prior authorizations, tiered formularies, pay for performance alternative payment models, value-based insurance design, and then medical liability reform. So I'm going to go over a couple of these here in this slide. The payer system reform is really looking at integrated health systems like the VA or Kaiser, where the insurer as well as the healthcare delivery system and the physicians are coordinated together as one group. And they've been able to show reductions in low value care. But obviously those are more unique systems. Another area is around coverage with evidence development. And so you see this as, Medicare has done this in a couple of areas, sort of in recent years around left atrial closure devices, where they approved coverage for the device, but in very strict criteria. So in this case, patients with AFib and elevated stroke risk, the inability to take long-term anticoagulation, and that they had to have a formal shared decision-making process associated with this, as well as enrollment in a registry. The last area is around, that I want to mention here, is around medical liability reform. And so there have been some studies, and this was a nice study done by my colleague here, Steve Farmer, who's now also works with Medicare, that looked at states that had implemented medical liability reform, essentially caps on malpractice suits. And what they were able to show in those states that they had modestly fewer cardiac catheterizations and revascularizations. What we don't know from that study is, were those low value caths and revascularizations or high value caths and revascularizations? Because obviously that would make a difference. But it does seem that there is some, at least modest, effect from medical liability reform. A couple other interventions, more on the insurance side, are things like tiered formularies, which I think we're all familiar with. That when we prescribe a medication for a patient, if it's a tier 1 medication, they might have no copay or maybe just $5, and if it's a tier 3 medication, they might have a 20 or 50 or a couple $100 copay with that medication. The challenge, I think, with tiered formularies is that they've largely been driven thus far by what the insurance companies negotiate with the pharmaceutical companies. If this were to be implemented, it would have to be more driven by whether this is a low value or a high value type medication, or the same thing could be taken for testing or procedures. And that's what leads into this idea around value-based insurance design, which is an interesting concept, and there's work looking at this. But the example would be, if you look at sort of a high-value stress test for an intermediate risk patient, There, the cost sharing, this is just an example, might be 90% the insurer and 10% the patient. But if it's a low value annual stress test in an asymptomatic patient, the cost sharing would be 10% for the payer and 90% for the patient. So, the idea being that creating these financial incentives around high value testing. Again, this is still somewhat preliminary, and there's ongoing work testing these sort of value-based insurance designs. But obviously, there's a big concern with this around access as well as equity and how approaching these sort of interventions. So another way that has been out there is prior authorization, which is something that I know is the bane of our existence for many of us in many areas. It is effective. Studies looking at imaging have shown that it decreases imaging overall by about 15%. Effective in that regard. Whether it's effective in reducing low value testing is a little bit less clear. And I think certainly there is a real concern around, is it just kind of decreasing utilization overall? And there were a couple studies back in 2017 which looked at prior authorization for PCSK9 inhibitors. In this case, it also looked at ezetimibe in indicated conditions, so what you would consider to be a more high value use for the medication. And so when you look at this, these are in a claims database for both patients with familial hypercholesterolemia or ASCVD. And you can see that they, at least as best can be determined by a claims database, meet criteria for PCSK9 inhibitors. And what you can say is that in those that have presumptive familial hypercholesterolemia, 63% were rejected despite having an LDL greater than 190 on lipid lowering treatment, which would be an indication for a PCSK9 inhibitor. And then if you look at those with ASCVD, whose LDL was greater than 100 while on lipid lowering treatment, again, about 60% got rejected. And then you can see there's quite a few that just got abandoned as well. So, patients or the physicians who just kind of gave up on the process. So I have concerns about prior authorization. It is a tool, but I think if applied, it needs to be done very carefully. And then there are value-based payments. And so these are systems that we all have been learning about and participating in, and basis for a whole nother talk. But whether it's pay for performance or combo care organization, episode-based payments, or some of the newer physician-focused payment models like the direct payment, direct contracting for primary care. And these approaches are meant to share the financial incentives or the financial risk with healthcare providers while ensuring quality. So the thought is that by taking a more sort of global look at this, it would incentivize healthcare providers to be more focused on reducing low value care and delivering high value care to patients, like statins for patients for whom it is indicated. So throughout all of this, it's really important that we focus on health equity. And this was a big focus of our group that was writing this scientific statement, because we know that there are really pervasive and persistent gaps in the delivery of cardiovascular care because of structural racism and bias that have been demonstrated for many years and across a wide range of areas. And so when implementing interventions to reduce low value care, it might unintentionally worsen disparities if we don't keep at-risk populations in mind as we're developing those interventions. And I'm going to go through a couple of mechanisms where equity plays into interventions to reduce low value care. So looking at heterogeneity of effects and applications, when we look at something like prior authorization requirements, this was a survey put out by the Association of Black Cardiologists and the American College of Cardiology a couple years ago. And when asking about prior authorization requirements, 3/4 of these cardiologists felt that the prior authorizations worsened disparities in healthcare. as well as you can see about 50–60% saying increased patient confusion, medication discontinuation, and interruptions in patient care. So when you look, so the heterogeneity of effects and application, when you look at something like prior authorization, the concern is that it worsens disparities by, for certain groups of patients, it's easier to navigate, or their healthcare providers are navigating those prior authorization requirements and better than for patients of color or those who have language or socioeconomic barriers. And then, but when you look at community resources, this is an interesting study which actually shows a potentially way to mitigate some of this. So this is a question of, are there, as we look at interventions, are there going to be financial barriers that particular communities have that limit their the ability to get high value care as we're looking to lower low value care? So this was an interesting study from several years ago called the MI-FREE trial, which put in place a randomized trial of eliminating cost sharing for secondary preventions post-MI. So these would be things like statins or beta blockers, MI. So there would be no cost sharing. Medications for the patients are free of charge. So the initial study, which was published, showed a significant improvement. This is a sub-study that was published in Health Affairs subsequently, which showed that among non-white patients, you see a really substantial reduction in major vascular events with this intervention compared to the blue line, which is the usual coverage. And when they looked at patients who were white, that there was not the same benefit. So it seems that the benefit in the overall study, when you look at the sub-study, the benefit was amongst non-white patients, which suggests that that this was a helpful intervention in terms of improving health equity. And then next are the financial incentives, and I'll talk through this the results of this study in a moment. But when we look at some of the financial incentives and looking at some of those pay for performance or alternative payment model programs that I talked about just a moment ago, there is a wealth of literature that has shown that many of these programs worsen healthcare disparities. I did work several years ago looking at the hospital value-based purchasing program and showing that the formula that they use favored socioeconomically advantaged hospitals. And so you end up getting what's called sort of a reverse Robin Hood effect, that the lower socioeconomic hospitals, money's transferred to the wealthier hospitals. And then probably the most literature around this has been around the Medicare hospital readmission reduction program. And so there's been a big debate in the policy community about whether we should be risk adjusting for socioeconomic factors. And there have been some big groups like the National Quality Forum that have come out and said that that should be done. And then the federal government came out with a framework for this a couple of years ago. And so in the Medicare hospital readmission reduction program, they did begin as a way for doing this by risk adjusting for patients who are dual eligible, meaning that they have both Medicare and Medicaid, which is a pretty well validated approach for indicating patients of lower socioeconomic status. And so when they began adjusting for that, what they found was that in that group with the most dually enrolled patients, that they had a decrease in their penalties, at least a trend towards it, not statistically significant. And that was driven by hospitals that had the highest minority population, as well as those in rural areas, which are two areas where we've seen disparities across the country, and that in previous work have seen in the hospital readmission reduction program that they were disproportionately penalized. These are modest effects, but it's a suggestion that in a large Medicare program that we can make some improvement towards health equity by looking at how the financial incentives are arranged. So lastly, I'm just going to talk about how we put this all together into a framework to reduce low value care. And so for this, we looked at a couple different approaches of how we can put this all together. And, essentially, there are a variety of different interventions, and we've gone through many of these. But any one of them in and of itself doesn't have sort of overwhelming data to show its benefit. And so this seems to fit most closely with what's called the social ecological model of health promotion. So taking that sort of model and applying this to reducing low value care is seeing that affecting change really requires acting simultaneously across multiple perspectives. And I'm going to show you that in a moment. It also requires thinking about de-implementation principles. So we have tests or procedures that we do that are commonly accepted. It's very difficult to de-implement them, to stop doing things that we're already doing. And so this has to be thought of along three sort of domains. So one, the evidence. So how strong is the evidence? If you have large randomized controlled trials, hopefully more than one that are convincingly showing that a particular intervention or diagnostic tool is low value, then that is important as we look towards de-implementation. Next is eminence. So essentially, how do we pull in the various stakeholders? And that's really important. So that's why, as we've talked about this, American College of Cardiology and the American Heart Association have been involved in these so that cardiovascular healthcare providers have a voice in this. And patients need to have a really important voice in this as well. Because as I've emphasized throughout this talk and as we did in the scientific statement, the patient perspective is really foremost and or needs to be foremost in all of this. And then lastly is the economics. So making sure that the financial incentives are aligned to make sure that that we're able to achieve this de-implementation, because if the financial incentives are going in the other direction, it's going to be very difficult. A couple other considerations, focusing on those areas of highest impact. So when you look at it both in terms of the number of tests performed and the cost of those tests and how low value they may be. And then lastly, but perhaps most importantly, as we've addressed, is ensuring that we are improving health equity as we move through this. And so this model that we came up with looks at it starting with the patient and caregiver through the clinician, health system, payer, and policymaker, and a variety of the different interventions that we've talked about going across those different groups and across time, and that it's going to be likely a combination of these various effects guided by the preferences of our patients and the science and the perspective of us as physicians and other caregivers as we try to work to decrease low value care. So I'm going to end with just saying, I think that there are probably many medical students here on this grand rounds, and we're physicians, we are healers, and there's a lot of talk here around cost and cost benefit ratios, and sometimes it can get a little bit foggy as we go through all of this. And so I always like to reference back to a wonderful quote from Don Berwick, who's one of the real sort of leaders in the field of quality, in a beautiful essay called To Isaiah that he published a couple years ago. It says, when we're sort of lost in this way, or at least a little confused, there is a way to get our bearings. When you're in a fog, get a compass. I have one and you do too. We got our compass the day we decided to be healers. Our compass is a question and it will point us true north. How will it help the patient?